Respected judges, my dear colleagues and students, the topic of my presentation is mucormycosis, recent complication in COVID-19 patients. Mucormycosis refers to infection caused by fungus in order of mucorales. Most common species are Rhizopus, Rhizomucor, Cunningham-Mela, Epiphysomi, Absidia, mucor. Major route of infection are the inhalation, ingestion, traumatic, inoculation. Pathophysiology of mucormycosis involves angioinvasion, vessel thrombosis, tissue necrosis. Epidemiology of mucormycosis involves the prevalence of mucormycosis varies from 0.0052 to 1.7 per million population. It is more common, 80 times more common in the India as compared to developed countries. 40,000 cases of mucormycosis were reported in 2021 in the month of June internationally. It involves 1% of patients which are immunocompromised patient having the low immunity. Mucormycosis carry very high mortality. It is around 50% to 80%, but there's no prediction for sex. The clinical presentation of mucormycosis shows the 5 clinical forms: rhinocerebral, pulmonary, gastrointestinal, primary cutaneous, disseminated. Among all these 5 forms, rhinocerebral type is highest type of mucormycosis. Predisposing factors are the diabetes mellitus, which is the most common factor, and having the diabetic ketoacidosis, patient with traumatic ulcer, catheter, patient having a steroids therapy, immunocompromised patients, malnutrition. Rhinocerebral type of mucormycosis, it is 50% more common in diabetic patients. 50% cases of total cases of mucormycosis usually occur in diabetic ketoacidosis that leads to disruption of host defense mechanism, thereby permitting the growth of Rhizopus rhiza. Rhinocerebral mucormycosis, the clinical feature of the rhinocerebral mucormycosis, the onset occurs with the nasal stuffiness, epistaxis, and facial pain. Later, proptosis, chemosis, and ophthalmoplegia, fever, confusion, black necrotic eschar on the nasal, turbinate, or palate. Diagnosis: punch biopsy of the lesion followed by the fungal stain and culture. Histological examination revealed characteristic broad branching hypha of rhizopus invading the tissue. CT or MRI of the head reveals air fluid level in sinuses and involvement of the deep tissues. The role of dentists in the care of mucormycosis is very important. In patient can Dentists can suspect the cases of mucormycosis in the early stages when the patient is recovered from the COVID-19. Patient is diabetes, having diabetic, patient is immunocompromised or is suffer from long-term hospitalization, or he is using rampant steroids. Internal finding of mucormycosis, there is atypical unilateral facial or sinus pain, black necrotic eschar, unexpected toothache or mobility, black pigmentation in mouth or palate or the alveolar ridge, or there's foul smell. The treatment for mucormycosis involves the correction of acidosis, antifungal treatment, surgical debridement, proper hygiene. Result of surgical debridement leads to psychological trauma and disfigurement and aesthetic loss of the patient. And at the same time, it causes the palatal continuity defect, which leads to communication between the nasal and oral cavity. And further, it leads to difficulty in deglutition, difficulty mastication, speech difficulty, nasal regurgitation. So, in prosthetic view, the treatment can be divided into immediate surgical obturator, delay surgical obturator at the 7 to 10 days of surgery, interim obturator 3 to 4 weeks of surgery, definitive obturator after the 3 to 4 months of surgery. Establishment of oral nasal partition leads to when obturator is given, it prevents a blockage between the communication of oral as and nasal cavity, which facilitate the swallowing, mastication, facilitate the speech, reduces the risk of oronasal infection, support the nutrition of the patient, and same time the patient feels the psychological well-being. Prosthodontic consideration, defect after debridement of mucormycosis, unpredictable, indefinable advancement of fungus. Clinically, additional debridement procedure may required. Mycelial tissue may be ischemic, precluding the use of skin graft to cover the raw tissue. Designing and modification cannot be done because of indefinable extension. This is one quiz report. This was one patient of around 30 years old who reported the Department of Prosto PGIDS Rohtak. He was complaining of the facial swelling on the left side of the face, and same time he was complaining of swelling of the eyes. Intraorally, if we will examine, we can see the necrotic tissue into the palate, and if tooth condition is seen, we can see all the teeth there's no caries, and periodontally all the tooth were in good condition. So the treatment plan was categorized into extraoral surgical plan, intraoral surgical plan, and prosthetic plan. Extraoral, there is endoscopic debridement and the general anesthesia. Intraorally, there is a local debridement of the palate, and prosthetic obturator was planned. So we can see we have taken the exam, we have taken the impression of the patient with alginate, and finally the cast was prepared. This is the prosthesis made, obturator was made, and it is in position, and we can see the debridement, local debridement of the palate, hole, communication between oral cavity and nasal cavity, and this is the final prosthesis in situ. So this was the instruction, final instruction given to the patient: cleaning twice a day, soaking the prosthesis overnight into the solution or into the liquid. So conclusion, dentists can be in position to be the first one to find initiation of the condition. A simple tooth mobility may be taken as caution and can help in detection of the problem. Further diagnostic aids can help in early diagnosis. Prompt treatment may be initiated, which will minimize complication, morbidity, mortality resulting from the mucormycosis. Thank you. These are my references. Thank you. Thanks again.